You probably don't notice it happening. You're scrolling through your phone, driving your car, working at your desk, and your chin is slowly drifting forward. Your upper back is rounding. Day after day, hour after hour, the bones of your cervical and thoracic spine are being loaded in a position they were never designed to hold for extended periods. And over months, over years, the body does what it always does when a structure is under chronic stress. It adapts. Collagen fibers begin to reorganize. The posterior ligaments of the upper spine stretch and weaken. The anterior vertebral bodies experience increased compressive load. The deep cervical flexors, the muscles designed to hold your head in neutral, switch off from chronic disengagement. And what you're left with is a visible, palpable deformity at the base of the neck and top of the thoracic spine, a forward head posture, a thoracic kyphosis, what many people call a Dowager'S Hump or a widow's hump. And here's what no one is telling you clearly enough. This is not just cosmetic. This is a structural shift that changes how you breathe, how you balance, how much force travels through your cervical discs, and ultimately, how you age. A head that sits 2 inches forward from its neutral position adds roughly 30 pounds of effective force on your cervical spine. That's not an estimate. That's basic biomechanical physics, documented in research published in Surgical Technology International. 30 pounds. And your body is carrying that load every waking hour. Every time you look down at your phone, every time you lean toward your computer screen, every time you drive without your head resting against the headrest. The load is accumulating, and the body is adapting around it. There's another consequence that rarely gets mentioned in these conversations. When the thoracic spine rounds forward significantly, the rib cage tilts downward at the front. This compresses the thoracic volume, the space your lungs occupy. Research published in the Journal of Physical Therapy Science has shown that increased thoracic kyphosis is associated with reduced forced vital capacity, meaning reduced maximum breathing volume. Your lungs cannot fully expand when your thoracic spine is collapsed forward. And if your lungs cannot fully expand, you are chronically under-oxygenating at the cellular level. That produces fatigue. That produces cognitive sluggishness. That contributes to the kind of low-grade exhaustion that people in their 50s and 60s chalk up to aging when it is in fact partly structural. This is why the Dowager'S Hump is not a cosmetic problem. This is a breathing problem. This is a neurological load problem. This is a bone density problem. And it is treatable at every age with the right approach. So if you're watching this channel for the first time, I want to be straightforward with you about what this channel actually is. This is not a channel that tells you the system is broken and you've been misled by everyone around you. That's not what evidence-based medicine looks like, and it's not what I do here. What I do is fill in the gaps, the things that don't fit into a 12-minute primary care appointment, the nuance that gets lost when protocols are designed for populations rather than individuals. If that's what you're looking for, consider subscribing. We're building toward 100,000 subscribers, people who want real clinical information delivered clearly, without spin, without alarm, and without oversimplification. Hit the button and come with us. Now let me tell you about a patient I'll call Margaret. She came in at 67 years old. She'd been told she had osteoarthritis. She'd been told to take anti-inflammatories as needed and maybe do some gentle stretching. And she had been doing exactly that for 4 years. But nobody had actually looked at the full clinical picture. Nobody had done a thorough postural assessment. Nobody had evaluated her deep cervical flexor strength, her thoracic mobility, her hip flexor tightness, or whether her footwear and workstation were actively driving the problem every single day. When we did a complete assessment, what we found was a cascade. Her pectoralis minor muscles were severely shortened, pulling her shoulders forward. Her levator scapula and upper trapezius were overactive and hypertonic, essentially trying to compensate for a deep cervical system that had stopped working properly. Her thoracic extensors were inhibited, and the hump itself, the visible accumulation of tissue at C7 to T1, had developed in part because the body was laying down fibrous tissue to protect a chronically stressed junction. This is not corruption. This is not malpractice. This is a gap between what a routine appointment is designed to assess and what actually needed to be assessed. And it meant that for 4 years, the root cause had been untouched. Margaret had been managing symptoms. No one had addressed the mechanism. When we finally addressed the mechanism, over 3 months of consistent exercise and ergonomic correction, her craniovertebral angle improved by 11 degrees. Her reported neck pain decreased significantly. Her breathing capacity, measured by a simple peak flow meter, improved. And she told me she felt taller, not because anything had dramatically reversed, but because the structural load on her spine had decreased enough that her nervous system was no longer working so hard to compensate. Let me explain the core physiology here, because once you understand the mechanism, everything else makes sense. Think of your spine as a suspension bridge. A healthy suspension bridge distributes load evenly across all its cables and anchor points. Now imagine that the main tower in the middle slowly starts to tilt forward. The cables on the front side go slack, the cables on the back side are pulled taut, stretched beyond their design tension. The anchor points on the compressed side start to bear more vertical load than they were engineered for. If you leave that tilt in place long enough, the bridge doesn't just look different, it starts to structurally remodel around the new geometry. That's what's happening in your spine. The thoracic vertebrae are wedging anteriorly under sustained compressive load. The posterior ligamentous system, the supraspinous and interspinous ligaments, is chronically elongated and losing passive tension. The intervertebral discs are being loaded asymmetrically, with more pressure on the anterior border. And the soft tissue at the apex of that curve, at the C7 to T1 junction, begins to accumulate a localized fat pad and fibrous tissue because the body is doing its best to protect a junction that's under mechanical stress. The clinical term for the structural change is postural kyphosis, and when there's a significant soft tissue component, we call it a cervicothoracic kyphosis with associated lipodystrophy at the apex. But the analogy holds. The bridge is tilting, and everything is remodeling around the tilt. The goal of exercise is not to fight the remodeling, it's to reverse the mechanical input that's driving it. Exercise 1, the deep cervical flexor chin tuck, the foundation reset. This is the most important exercise on this list, and it's also the most misunderstood. When most people hear chin tuck, they tuck their chin and think they're done. They're not. What you're actually trying to do is activate the deep cervical flexor muscles, specifically the longus colli and longus capitis, while simultaneously inhibiting the superficial flexors like the sternocleidomastoid. This distinction matters enormously, and it's supported by research from the University of Queensland, where Professor Gwendolyn Jewell and her colleagues have published extensively on cervical motor control and the specific dysfunction of deep flexor inhibition in people with forward head posture and neck pain. Here's how to do this correctly. Lie on your back on a firm surface. You're not looking for a soft mattress. Firmness matters because you need feedback from the surface. Place a small, rolled towel under your neck to support the cervical curve if needed. Now, without lifting your head, gently nod, as if you're saying yes, very subtly. Not a big movement, a tiny, controlled upper cervical nod. You should feel a gentle flattening of the curve at the base of your skull against the surface. Hold that position. 10 seconds. Breathe normally. The key signal that you're doing it correctly is that your neck veins are not bulging, your jaw is not clenching, and your sternocleidomastoid, the big strap muscle on the side of your neck, is not firing hard. If it is, you're using the wrong muscles. Reduce the effort until you feel the activation settle deeper, closer to the spine itself. 10 repetitions, 10-second holds, twice a day. Research on craniocervical flexion training, including studies published in the Journal of Orthopedic and Sports Physical Therapy, shows measurable improvements in deep flexor endurance and reduction in forward head posture over 6 to 8 weeks of consistent practice. 6 to 8 weeks, not 6 to 8 days. This is a motor reprogramming exercise, not a stretch. You are teaching the nervous system to recruit a muscle group it has largely abandoned. The deep cervical flexors, once properly activated again, begin to restore the natural lordotic curve of the cervical spine, which pulls the head back over the shoulders and reduces the mechanical load on that C7 to T1 junction. Exercise 2. The thoracic extension over a foam roller, mobilizing the locked segment. The thoracic spine is the architectural apex of the Dowager'S Hump, and in most people who develop this condition, the thoracic vertebrae, particularly between T4 and T8, have become hypomobile. They've stiffened. They've lost their natural capacity for extension. And when that happens, the body finds extension somewhere else, usually at the lumbar spine, causing hyperextension there, or by allowing the cervical spine to hyperextend, which dumps more load into the C7 to T1 junction. You need to restore thoracic extension mobility directly. This is how. Take a standard foam roller, medium density, not the softest you can find. Place it perpendicular to your spine at the level of your mid-back, roughly where your bra strap would sit, or about T6 if you're thinking anatomically. Support your head with your hands interlaced behind your neck, not pulling your neck forward, just supporting the weight of your head. Now let gravity do the work. Allow your thoracic spine to extend over the roller. Not a forceful push, a passive, supported extension. Breathe out slowly and feel the thoracic joints mobilize gently. Hold for 20 to 30 seconds. Then carefully shift the roller 1 or 2 inches higher and repeat. Then 1 or 2 inches lower and repeat. You're working the T4 through T8 regions systematically. If you feel sharp or shooting pain, stop. Mild achiness and stiffness as the segments mobilize is expected. Sharp or radiating pain is not. Do this once daily. The evidence base for thoracic extension mobilization and postural correction is well established in physiotherapy literature. Research published in the Journal of Manual and Manipulative Therapy and studies on upper cross syndrome management consistently support thoracic mobility work as a necessary precursor to scapular repositioning and cervical correction. You cannot fix the top of the bridge if the middle is locked. One important note on progression. As your thoracic mobility improves over the first 2 to 3 weeks, you may find that you can go deeper into extension over the roller with less discomfort. That's a sign the facet joints are mobilizing and the soft tissue around them is loosening. Lean into that progress. The goal is not comfort. The goal is restoration of range. Before I go to exercise 3, I want to pause and ask you something. And this is genuinely useful information, not just a comment prompt. Drop your age in the comments below, because here's why it actually matters for this specific condition. The biology of postural correction shifts significantly after the age of 65. Before 65, the thoracic spine typically retains enough disc hydration and facet joint mobility that mobilization and strengthening exercises can produce fairly rapid structural improvement. We're talking measurable changes in forward head posture angle within 8 to 12 weeks of consistent training. After 65, and especially after 70, 2 things change. First, the intervertebral discs have lost significant water content. We call this disc desiccation, which means the mechanical compliance of the spine is different. Mobilization techniques need to be gentler and more graduated. Second, the risk of osteoporosis becomes a real clinical consideration. In women over 65, the prevalence of osteoporosis in the thoracic spine can exceed 30%. The foam roller exercise I just described is safe for most people, but if you have known or suspected osteoporosis, you must not apply direct posterior pressure to the vertebral bodies through a roller. You should instead work with a physiotherapist on a modified thoracic mobility program. Supine thoracic extension over a rolled towel is often safer in that population. So your age genuinely changes the prescription. Drop it below so I can speak to your specific situation more directly in future videos. Exercise 3, the wall angel, retraining scapular position and activating thoracic extensors. The wall angel is the most underrated exercise for Dowager's Hump correction, and it is also the exercise that most people do incorrectly the very first time they try it, which makes it worth explaining in detail. Here's the setup. Stand with your back against a smooth wall, feet about 6 inches away from the wall. Your head, upper back, and buttocks should all be in contact with the wall. If your head cannot touch the wall without forcing your chin up, that's important diagnostic information right there. It means your forward head posture is severe enough that neutral cervical alignment requires active correction just to achieve wall contact. If that's you, don't force your head back. Just note it and work within your range. Now bring your arms up to the wall with elbows bent at 90 degrees, like a goalpost position. Backs of your hands and your elbows should both be touching the wall. This is where most people discover they can't do it. Their elbows pull away from the wall because their pectoralis minor is so shortened that scapular retraction and posterior tilting are mechanically blocked. If that's you, don't force it. Start with just the backs of your hands touching the wall and elbows wherever they naturally fall. Now, slowly slide your arms upward, like a snow angel, while maintaining contact between your hands and the wall. Move only as high as you can without your lower back arching excessively away from the wall or your ribs flaring forward. Lower them back down. Repeat. 10 repetitions, 2 sets. What you're training here is a coordinated pattern of lower trapezius activation, serratus anterior engagement, and thoracic extensor recruitment, all while simultaneously inhibiting the overactive upper trapezius and pectoralis minor. This is a pattern that research on scapular dyskinesis and upper cross syndrome, including work published in the American Journal of Sports Medicine, identifies as central to restoring normal scapulohumeral rhythm and reducing the forward rounded shoulder posture that drives thoracic kyphosis. Progress this exercise over time by starting to bring your elbows closer to the wall. The day you can do 10 clean wall angels with both elbows and both hands touching the wall throughout the entire movement, that's the day your thoracic mobility and scapular motor control have genuinely improved. Now let me give you what I call the posture reset protocol, a 10-minute daily routine that combines all 3 of these exercises in a specific sequence that maximizes their effectiveness based on the principle that mobility must be established before stability can be trained. Here's exactly how to run it. You do not need any equipment beyond a foam roller and a wall. Minute 1 through 3. Foam roller thoracic extension. Set the roller at T6, spend about 20 seconds at each level, working from T8 up to T4. This mobilizes the locked segment first. You're opening the door before you try to walk through it. Minute 3 through 6, deep cervical flexor chin tucks. 10 repetitions with 10-second holds. Lying on the floor after you've just mobilized the thoracic spine is ideal because the improved thoracic position actually gives the cervical spine better mechanical input to work from. Think of this as resetting the top of the bridge after you've repositioned the middle tower. Minute 6 through 10, wall angels. 2 sets of 10, slow and controlled, with a full 2 seconds on the way up and 2 seconds on the way down. By doing these last, you're training the scapular stabilizers in a neurologically fresh state. The foam roller has improved thoracic extension range, the chin tucks have activated the deep cervical system, and now the wall angels can express proper scapulohumeral mechanics because the foundation has been laid. This sequencing matters. Randomizing these exercises or doing them in isolation produces slower results. The protocol works because each step prepares the system for the next. Do this every day, not 5 days a week, every day. The neurological reprogramming that's required here demands repetition frequency that occasional exercise cannot achieve. Now here's what the research says about realistic outcomes, and I'm going to be direct with you because I think you deserve honesty more than optimism. A 2019 systematic review published in the Journal of Physical Therapy Science analyzed the effects of exercise interventions on forward head posture and found statistically significant improvements in craniovertebral angle, the primary measurement of forward head posture, after 6 to 10 weeks of consistent cervical and scapular exercise. That's the good news. The realistic news is that full reversal of a long-standing structural hump, particularly one with significant fibrous tissue accumulation at the C7 to T1 junction, is not typically achievable through exercise alone. What exercise does, what these three movements, done consistently, genuinely accomplish, is halt the progression, restore functional mobility, reduce the mechanical load that's driving the deformity, improve breathing mechanics by restoring thoracic volume, and in many cases produce a visible improvement in posture that changes both how you look and how you feel. That is worth doing. That is clinically significant. And in individuals who catch this early, in their 40s or 50s, before significant structural remodeling has occurred, the improvements can be substantial and lasting. This is why age matters. This is why starting now matters. Let me also address something that often gets ignored in conversations about the Dowager's Hump: the role of bone density and nutrition. The visible hump at C7 to T1 is not just a posture problem. In postmenopausal women especially, it is frequently driven in part by anterior vertebral compression fractures, small fractures of the front edge of the thoracic vertebral bodies that occur because bone density has dropped below the threshold required to withstand normal daily loads. The bone simply collapses forward under its own weight. This is why the Dowager's Hump has historically been associated with elderly women. It's not purely a posture problem. It's a bone density problem expressing itself through postural collapse. If you are over 55 and female, you need a bone density scan, a DEXA scan, as part of understanding this condition fully. Exercise alone cannot rebuild bone that is already fractured. You need to know what you're working with. If your bone density is within a healthy range, the exercise protocol I've described will be highly effective. If your bone density is reduced, you need to address that simultaneously through weight-bearing exercise, through adequate calcium and vitamin D intake, and through a conversation with your physician about whether pharmacological intervention is appropriate. Calcium intake recommendations from the National Osteoporosis Foundation sit at 1,200 milligrams per day for women over 50. Vitamin D, 3 at a minimum of 800 to 1,000 international units per day, with many endocrinologists now recommending 2,000 IU for adults with demonstrated insufficiency. These are not exotic supplements. They are the basic raw materials your bone-building cells need to do their job. Magnesium, often overlooked, is also a critical cofactor in bone mineralization. Many adults are insufficient, and a daily dose of 300 to 400 milligrams of magnesium glycinate supports both bone density and the muscle relaxation that makes thoracic mobilization more effective. And while we're talking about what's missing from the conversation, let's talk about sleep position and workstation ergonomics, because no amount of daily exercise will overcome 8 hours of harmful positioning. If you sleep on your stomach, you are rotating your cervical spine to one side for hours every night and loading the anterior disc structures in a way that actively drives forward head posture. Stomach sleeping needs to stop. Side sleeping with a pillow that fills the gap between your ear and your shoulder, maintaining a neutral cervical curve, is optimal. Back sleeping with a cervical support pillow that maintains the natural lordosis without pushing your chin forward is also excellent. Your monitor should be at eye level. Your phone should be at eye level when you're reading. If you are looking down at your phone for 2 hours a day, you are applying those 30 pounds of force to your cervical spine for 2 hours every day. And no exercise protocol will outpace that input. The exercises correct the deficit. The ergonomics stop the deficit from being rebuilt every day. The truth about the Dowager's Hump is this: it is not inevitable. It is not simply what aging looks like. It is the accumulated result of years of mechanical input that the body has adapted to And where there is adaptation, there is the possibility of readaptation. Your nervous system retains neuroplasticity well into your 70s and 80s. Your muscles retain the capacity for hypertrophy and motor reprogramming at every age that research has studied. The deep cervical flexors that have switched off can be switched back on. The thoracic spine that is stiffened can be mobilized. The scapular stabilizers that have been inhibited can be retrained. It takes consistency. It takes the right sequence. It takes understanding the mechanism rather than just doing random stretches and hoping something changes. But it is not beyond you. 3 exercises, 10 minutes a day, 6 to 12 weeks of genuine commitment. The evidence says this works. Your body can do this. Your health is your responsibility, not the pharmacy's. I'll see you in the next video.